So the objectives for today are to identify the various pediatric anxiety disorders and current research on something that we're calling atypical forms of anxiety that affect some children with autism spectrum disorder. So I'll talk more about this. It's a newer area of research, and we're working to collect information on this at one of the studies at the Mind Institute. I'm going to talk about recognizing the key components of CBT and considerations regarding whether this treatment is a good fit for certain children given their current abilities and needs. It's an empirically supported treatment for anxiety disorders, but it's actually not always the best fit for what's going on with the child. And we're going to talk about the effectiveness data on particular CBT programs for typically developing children and children with neurodevelopmental disorders. Okay, so neurodevelopmental disorders there are a few definitions out there, but they usually have the same kind of components within them. They have their onset in childhood or in the developmental period. They affect more than 3 areas of life function, so this could be like social, personal, academic, and they're expected to last for an extended period of time. So the DSM-5, our Diagnostic and Statistical Manual for diagnosing psychological and behavioral problems, they list the neurodevelopmental disorders. Here they are, and I put under other neurodevelopmental disorders, although it doesn't say this there. We have a lot of research going on at the Mind Institute for Fragile X syndrome and 22q deletion syndrome, so I put that on here as well. And my level of pink font indicates how much I'm going to talk about these various areas. So I'll talk the most about CBT for children with autism spectrum disorder. I'm going to touch on ADHD some, and intellectual disabilities, and along with that, I'm going to talk a lot about verbal skills needed and communication skills. So although I didn't highlight it, communication disorders will, I'll mention some that relates to that as well. Okay, so what is anxiety? The one thing I really want to be clear is that it's normal to have anxiety. We have it for a very important reason, and it goes back many, many years, and I'm going to actually read something from a website that I found to be really interesting to describe this. So we think of it as an automatic response, fight or flight response to perceived threats that allows us to protect ourselves from danger. So we need this. We need to have anxiety and fear to prepare ourselves for danger. So I think about, and most people think about anxiety as anticipatory. So it's something that you feel in anticipation of a future event that might be dangerous in some way or have a bad outcome, whereas panic is sort of like an immediate response to knowing that you're in a danger. So, if I think about myself and giving this talk at almost 37 weeks pregnant, I had a lot of thoughts about this talk that I haven't had about other talks, like, it's hard to breathe at this point of pregnancy. Are they going to think I'm really anxious because I'm like panting and trying to catch my breath? And, I'm hot all the time. So if I'm sweating, will they think I'm really anxious in an anxiety talk? So there's lots of these thoughts that we have before events that, a talk is one that typically raises anxiety for most people. But then I thought, oh, well, panic might be, if my water actually breaks up in front of all these people. So, the panic would be a reaction to something where I really felt like I was in danger. Hopefully I could handle that given my profession, but I don't know in that circumstance. So there's this distinction between kind of anxiety that's in anticipation of something and panic, and that both of these, in a lot of circumstances, are normal. So I just wanted to read something that was from a website. I'm not recalling the name today, but as you see here, my picture says people, or what's for dinner, or rather we used to be. So we talk about way back in time when humans walked around with dangerous animals and had to really worry and anticipate this type of danger. So, if you were back in that day and you were out taking a walk or something, you would want to be aware of whether a tiger was coming towards you. And so if you saw a flash of orange in the bushes, you might have some reactions that would occur. You might have an alarm go off, like this fight or flight response, to warn you that this is a danger. And so some things could happen. Your heart could beat faster and stronger, resulting in increased blood pressure. This moves blood into the large muscles of your arms, preparing you to fight, or your legs, preparing you to flight or run away. Many of your muscle groups will tense up in anticipation of this action. Your blood flow is diverted away from your skin surface and from your fingers and toes, so you can have paleness, tingling sensations, and cold feet. This way, if you really encountered a saber-toothed tiger, you would not, if it bit you, you wouldn't be as likely to bleed to death. Your breathing would also change from these slow breaths that originate near your abdomen to rapid increasing breaths. This would bring oxygen to your muscles, but also might make you feel dizzy or have a hot flash, especially if you don't actually run anywhere. And as the alarm continues to sound, your pupils will widen to get in more light so you can see your escape route. You'll begin to sweat, which in addition to keeping you from overheating, will make you slippery and harder to catch. And your whole digestive system will shut down from your saliva glands, resulting in stomach, producing nausea or constipation. So all of these changes that occur in our system when we have this response are geared towards helping us either fight or flight. If you do either of these and this threat is real, this would have helped you very well, because hopefully you'd get away from the tiger and you would be fine. But if you saw that orange flash in the bushes and you had all these reactions and you realized, oh, that was just a flower that was passing in the wind, moving around, you would just kind of be left like pale, tense, constipated, and sweaty. So this is like a really thorough description of what happens in our body, and the purpose of this is that when it's a real danger, we want this to happen, right? Like if a subway was coming towards you or a bus, you would want to have this reaction so you could get out of danger. But what happens in anxiety disorders is that people are having false alarms for danger. So the system is activating when you're not actually in a real danger. So we'll talk more about that. Okay. So along with this, in terms of kind of thinking about when anxiety is typical and when fears are typical, we have some developmental stages that we think it's based on research, it's more likely to have certain fears. So if you look here, in the first years of life, it's pretty normal for kids to have a phase of being scared of loud noises, strangers, new places and heights. And then if you get into the preschool years, being alone, being in the dark, animals, monsters under your bed, that's pretty typical for kids to have a phase where they might be scared of those things. School age, you tend to see more worries about negative evaluation from others, illness or bodily injury, things like ghosts and stuff like that, and being scared of natural disasters. They really don't understand them and how they work, and it tends to be a fear more common in that stage. In adolescence, we see more social concerns, more worries and fears about sports, grades, college SATs, and the future. So if any of these things occur in these stages and they're relatively short, they don't impair functioning, and the child can move on, then we think that's pretty typical. That's not something that is an area that needs to be addressed clinically. However, you could have a child have one of these fears in one of these stages, but it's so out of the proportion of what would normally go on. Or you could have a child who has one of these fears in a different stage. So to have separation anxiety and being worried about strangers and things when you're really young is pretty typical. But if this is happening to such a severe degree for a 10-year-old, then that is quite a difference in something of clinical concern. So now that we know that anxiety is normal to some degree, we all have it and it's there and it's important, and that there's developmental fears that are pretty normal and that come with kids, and usually they just pass on and they go. So now we're going to talk about how do you know when the anxiety rises to a level above and beyond what we would expect for for that child or for that age or for what's going on. So I'm going to talk some today about the ADIS, which is the Anxiety Disorder Interview Schedule. That's kind of our gold standard for diagnosing anxiety disorders. And there are 4 main components that we look at to think about if anxiety is excessive and needs clinical attention. So the first is severity. So we have the feelings thermometer here. This is something that's used when you're using the ADIS. And on this thermometer, to get at severity, you would this interview can be done with child, parent, or both. So if you're talking to them to try to get them to know how to use the thermometer, for severity, I would use an example. So I moved here from Philadelphia. Philadelphia is a bigger city. There tends to be more rats there than what I've noticed here. And so if I was really scared of rats, I would think about how severe or how scared I am. A 2 would be just a little bit. Like, if I saw one in the distance, I'd kind of be creeped out or grossed out for a minute, and then I could sort of just let it go. It'd be pretty quick, and it wouldn't make me really scared. A 4 is getting at the point where this light switch of kind of anxiety goes on, and you can't really turn it off. So this would be like, I saw a rat, or I'm thinking about rats, and I can't stop thinking about it, and it's really distressing me, and it's really causing me to be upset. A 6 would be if it was so severe that I was kind of having, for kids, it's more of like crying and a lot of behavioral things that you notice. I might have my heart is really beating hard. I'm getting really upset about it, and I really can't let it go, and I'm very upset. And an 8 would be I couldn't be any more scared of this rat. This would be like I'm in a room like this, and there's like 100 rats in here coming after me, and it's just the absolute highest you could go. So we get ratings in this interview of severity. How severe is the fear or the anxiety? We use the same scale for impairment or interference. So sometimes this is a little bit of a hard distinction for people. Impairment is how much it messes with your life. So you can be really scared of something, and it actually doesn't interfere that much. Like if me being scared of rats in Philadelphia could cause more interference than when I came here, and where I live now is very different. So interference, we would say, okay, a 2 is like it's a little bit of a problem. It's, you may not pass certain alleys if you think there are rats. You may walk a different way. It's not really messing with your life much. A 4 is when it's really a problem. So this is our cutoff for clinical concern. It's really a problem. It could be I wouldn't go over to certain friends' houses because their building might have more, I think they might have more rats there. Or I'm walking a different way to work and it's making me late for work. It's really interfering. A 6 is it's interfering even more. I'm sort of getting written up at work for being late. I can't stop thinking about these rats. It's causing me all these problems. And an 8 is like the absolute worst it could be. Like I'm either in my house and will never leave, or I need to be like hospitalized because I'm so worked up and it's interfered and messed up my entire life. So we want to always think about severity, impairment, and avoidance with anxiety disorders. How many things I just described that if I was having impairment and severity at that level, there'd be lots of things I'd be avoiding. Going to friend's house, walking certain ways, and then the duration. So as most of you know, for all anxiety disorders, there's a certain duration required of having this difficulty before you think it's more than just kind of a phase that could pass. So what I was saying earlier is, if I saw that flower and thought that that was a saber-toothed tiger, really seeing that flowers, it was sort of a false alarm for danger. I thought that it was something really dangerous, but it wasn't. So if children are having lots of false alarms for danger, and one of the ways I talk to them about this is like, have you ever had a smoke alarm go off because you've popped popcorn and it's burnt? So the smoke alarm is supposed to indicate a real danger, something that's serious, and we need to get out or call, 911. But if it's just popcorn, it was kind of a false alarm. That's not a real danger. And so kids are usually able to understand this, that they're having false alarms for danger and they're not actually in danger and they don't know that anything bad's going to happen at that time. Another way to think about it is realistic versus excessive anxiety and fear. In the children that I work with autism spectrum disorder, we really want to figure out, I mean, this is for all kids, but we really want to figure out if a skill deficit is present. So if a child comes to me and they say they're really, really anxious during reading, and they're so anxious and they're so upset about reading, and it's causing all these problems, and then I find out that their reading level is really far below where it should be for their grade, and they know that, so they're being asked to read aloud in class, but they have a really strong skill deficit that's not being accommodated, then I'm going to think of that anxiety as being a little more realistic, and instead of treating anxiety as it is excessive, I'm going to want to help that child, get the proper accommodations to support the reading or get them in a more appropriate reading, class or curriculum. So we want to always think about that. Is it a skill deficit, is it realistic, or is it really excessive? One teenager I worked with, we thought that she had social anxiety, and it was pretty clear social anxiety. She was really worried about what adults would think of her and if they'd be angry with her. And after spending some time with her, I figured out that she has no ability to recognize the variation in people's emotions. So she knows very happy and very, very angry, but she didn't even know there's like a neutral kind of in there. And so the continuum for her was, she knew if people were happy, and if they clearly weren't happy, she thought they could be angry with her at any second. So she was so anxious because around adults, she thought, I don't know if they're moving into anger, and I'm going to be really upset if they're angry and they yell at me. So instead of saying, okay, your anxiety is so excessive, we want to work on that skill deficit of emotion recognition in other people. Another thing to consider is whether the symptoms related to anxiety and not to another core deficit. So if you think about an autism spectrum disorder, I've had a parent tell me that the child's not participating in class, and they think that maybe they're anxious in class. And then you really kind of sort it out and you figure out the details and find out that they're not participating because they're engaging in repetitive behaviors. They're thinking about Pokemon the whole time in class versus they're not participating because they're scared of what other people will think of them. So that's obviously very different, but we want to make sure we're not saying something's anxiety when it's really about another core deficit. And then general behavioral dysregulation is not the same as clinical levels of anxiety. So I see this a lot in kids that get referred to me and they have ADHD, and one family, they call this the exciteds with their child. He would go up to people, seem really intense, ask questions really quickly, be in their face, be in their space, be all over. And they thought he was anxious, and through a lot of time spent with them and him, he was just behaviorally dysregulated. He wasn't anxious at all. He wasn't able to indicate this, and in every way I tried, it didn't appear that it was anxiety. It was more of behavioral dysregulation. So if it's that, we want to, consider that and not assume that it's anxiety. Okay. So why should we pay so much attention to anxiety? Most people in here probably know that this can be quite a problem, but just some details, 2 to 5% of children and adolescents meet criteria for an anxiety disorder at a given time, making it the most common emotional problem among youngsters. It often goes unrecognized and untreated due to reporting of physical symptoms. So especially with little kids, they might have a lot of stomach aches and headaches, but they can't say, I'm worried about something. And so if they don't have that ability to verbalize their internalized symptoms of worry or fear, then it might go missed. It's not all kids with anxiety, but a lot of kids are sort of those really quiet, shy kids. So they're not causing a disruption in school. They're just sitting there really, some people call it suffering in silence. So it's something that is missed sometimes. There's a negative impact in multiple domains. So there's research suggesting that these kids don't achieve as well as they could in school because they're so caught up by the anxiety, derailing of important developmental milestones. So I've worked with some teenagers that, dating is one of the questions that you ask about in the social anxiety disorder part of the ADIS. And I asked one boy, he was a little older teenager, and I said, "Oh, are you dating at all?" He was like, "No way, I can't even talk to a girl. There's no way, I've never talked to a girl in school." And he was horrified at the idea of it. But, at his age, he was already going to be a little bit behind in kind of understanding how this works and talking to girls. He wanted to, he just couldn't do it. Anxiety is often associated with depression and suicidal ideation. And shy and anxiety disordered children continue to show above average levels of interference into early adulthood if it's not treated. So it's not necessarily something that, it'll just pass or it'll go away. If it's at a clinical level, it really needs to be treated to not persist. And it predicts substance abuse problems, depression, and anxiety disorders in adults. So we think this is something that really needs a lot of attention. So now that's kind of more about anxiety in general. And now to switch to thinking a little bit more about anxiety in children with ASD and ADHD. So for ASD, the rates of comorbid anxiety disorders in ASD range from 40 to 84%. And I'm going to talk more in a little bit about why that's such a wide range. A lot of it has to do with the way that it's being measured. And we're trying to get better measures for this, and that's one that I'll describe to you. And another is there's been a lot of change in the field about how anxiety is diagnosed in children with ASD. So not that many years ago, people weren't giving a separate diagnosis. They were just saying, it's part of the autism, and even in Kanner's really early articles and work about autism, there's a lot of anxiety mentioned there. So some people were just saying, don't give something separate, it's part of it. We've had a shift in that. We think it's really important to give a separate diagnosis to understand what's going on, but also because we have treatments for it. So if it's not identified, the person might not get to the point of getting the treatment. So the next part is about, investigating these atypical forms of anxiety and appropriate treatment path. So I'm going to talk about these in a little bit, so we'll hold that thought. There's a question of awareness of reduced social skills leading to higher anxiety or vice versa. So if you have a child who has, these difficulties in social skills, like the teenager that I mentioned, that she really did not understand how to recognize where anyone, was on the emotional continuum. That made things very anxiety-provoking to her because she just felt like lost all the time. And she said, "I can't tell from their tone of voice, I can't tell from their face. I'm just like blind, like trying to, in every way, trying to figure out what someone is feeling towards me." And then excessive worry and distress regarding social situations may prevent the formation of meaningful relationships. So I talked about this a little bit, but particularly in kids with ASD, if they're feeling really anxious and they're not talking or they're not doing anything and even using their skills in school, they might miss out on friendships they could have and relationships they could develop. And anxiety problems can adversely impact school performance, peer relationships, family functioning, and further exacerbate the core deficits of ASD. So there are some kids that once you help their anxiety out some, everything else can seem a little bit better. The anxiety was really driving a lot of the problems. It's not like those other things will disappear, but it needs to be recognized. So in ADHD, the rates of comorbid anxiety disorders in ADHD range from 11 to 40%. The children with ADHD are known to have deficits with executive functioning, emotion regulation, and social skills. So through a lot of the research it's done, I guess it's not a surprise that anxiety would come along with it. I've worked with one adolescent who described to me that he has ADHD and social anxiety, and it really was so intertwined. He said that in math and English particularly, he had this really common experience of just sort of zoning out and not realizing that he wasn't paying attention. And then when he snapped back in, like many minutes later, he had like such a shoot up of anxiety because he realized he'd missed all the important instruction. And he was feeling really anxious because it would be like time to select groups, and he knew that he was worried that the kids would think he was dumb or stupid and not want to select him. So his ADHD kind of impacted, like went right together with his social anxiety in most of his academic classes until that was really targeted. He was a very bright kid, but felt like he was getting dumber because he was missing these concepts so often, and he was really worried what his peers would think of him because of this. And when compared to children with ADHD or anxiety disorders alone, children with comorbid ADHD present with greater symptom severity, attentional problems, school fears, and decreased social competence. And I'll show you towards the end that there's research that CBT in children with ADHD, they do worse than children without ADHD, so it can be done, but they don't have as good of outcomes, and we'll talk about the details of why that might be. And then there's these, and this is one of them, there's complexities involved in treating anxiety if ADHD is not well managed. So when you're doing a lot of the, you're doing exposures in CBT, you're exposing them to a feared situation. If they're not focusing on it and they're inattentive at that time, it might impact their ability to habituate to it. So we expect if you're exposing a child to a fear that they have, like you're, exposing them to looking at spiders or something. And if they're not paying attention to that at all, we would think that that might not be as likely to work and decrease that fear over time if they're really inattentive. So there's some discussion of that we'll have. Okay, so there's this new area of research I mentioned on these atypical anxiety or fears in children with ASD. So it's not thought that this is necessarily specific to children with ASD, but that's where the research is being done right now. And she's calling it atypical because there's traditional anxiety disorders that are in the DSM and that we know a lot about through research. And she's calling this atypical because they're just not those. And there wasn't a great other word for it. The she that I've been talking about is Dr. Connor Kearns. She is at Drexel University in Philadelphia, and this is her line of research. And what she wanted to figure out is she was noticing clinically that a lot of kids with ASD had symptoms of anxiety, but they were being diagnosed with what's now other specified anxiety disorder. It used to be anxiety NOS, because it didn't really seem to fit into one of the categories that we had in the DSM. And the reason why that's not so great is it's just such a vague term, and it doesn't really help clinicians know what exactly they're treating, and also then it's harder to do research on it to know if the treatments are helpful. So she was sort of noticing lots of symptoms in kids with ASD that didn't seem to fit the strict criteria of the traditional anxiety disorders. And anxiety in general is her area of research in kids with ASD. So she wanted to know, is anxiety a universal consequence of ASD? Like, do almost all the kids with ASD have it? Is it truly a comorbidity, so a disorder that's distinct from ASD but very similar to other anxiety disorders outside of ASD? Or a unique manifestation of anxiety that's altered by the fact that it's coming along with ASD? So she's sort of doing lots of work in this area, and she developed something called the Autism Spectrum Addendum. So the DSM-5 version of the ADIS that will be coming out, I think within the year, will have this Autism Spectrum Addendum as part of it that can be purchased when it's published. And so it has a lot of components involved in it. She came actually to the Mind Institute this year to train a couple of us because we're using this measure on the Autism Phenome Project, this round of it. It's a complicated measure. We're really working to learn it and understand it, but think it's going to be very helpful to figure this out. So I'll take you through some of the areas. So you would go through the ADIS as you normally would in asking the questions related to the traditional anxiety disorders, and then you would also go through these areas that are these atypical areas, and then there's differential diagnosis areas. So for example, if you went through the social anxiety disorder questions and the child is not, the crux of social anxiety is fear of negative evaluation from others. So if they're not able to indicate that, they don't say they get embarrassed by what other kids think of them, they might not have the verbal ability, or they just aren't indicating that at all, you would consider atypical social fear. So this would be kids who seem really anxious in social situations, but there's none of that other part that really is supposed to be there to get a social anxiety diagnosis. Atypical specific phobia, we have the main phobias that are traditionally seen, needle phobia, dentist, doctor, heights, all of those. But Dr. Kearns has noticed, and I'm sure many of you have over time, that there are some fears that kids with autism have that seem pretty different. So up on the far left, that picture is like this prickly pod. It's like a seed pod that falls out of trees. I saw a patient that she had an extreme phobia of these dried prickly pods. And it just seemed kind of unusual. It's like, what is it about that dried prickly pod that she wouldn't go to parks anymore, she wouldn't go outside at recess. It was really causing extreme interference in her life, and it seemed a little atypical for a phobia. I also have a picture up here of a black toilet. I've treated a patient who had an extreme fear of black toilets. So the other toilets were okay, but she was collecting information in a book of everywhere she'd been that had a black toilet, so she could avoid going back there. So it was causing a lot of interference, because if they went anywhere in public, she would also want her mom to go in first to see if it was a black toilet versus a white toilet. And then, she had to write it in this book and then would never go back there. So that seems kind of atypical. What is it about the black toilet? That's not one of the more traditional specific phobias that we see. Special interest fear. So I have kids coming to the clinic where they have a diagnosis of OCD, and it's because they're so obsessed with their special interest, like their video games. And so somebody gave them a diagnosis of OCD because they saw it as they're really, really obsessed about it, and they have to get the video game, so they have to that's like the compulsion, they have to have it, and they're so distressed until they have it, and then that relieves the anxiety. We don't see that as OCD, because OCD is really about you're trying to prevent some kind of dreaded outcome or feared outcome. And so, but it is a source of anxiety, and a lot of parents see it. So I have here, video games ruined my life. Good thing I have 2 more, because this is something parents are really concerned about and they're trying to manage, but it doesn't actually fit an OCD diagnosis or more of the traditional areas. Negative reaction to change and fear of change. So I have a map on here because many of you might have encountered this before. Some kids with autism spectrum disorder they feel like they have to go, all the routines have to be the same. They have to go the very same way to, this is from the Mind Institute to Arden Mall. And if you go the other way, that's going to be a huge problem. They're asking about it beforehand. They're really worried. They're really anticipating. So that's about fear of change. That's not necessarily the same as generalized anxiety disorder that would have lots of worries about daily events. And then my little guy having a tantrum, lots of negative reactions to change, even sometimes changes that might be positive for some kids, like getting out of school early. There are some kids who get really upset and will tantrum because it's just a change and they're not able to handle the change. So these are areas assessed within the ASA. And there's also lots of considerations. So if you're trying to decide whether you should diagnose a child with social anxiety disorder, we check in on questions related to, do they have friends? Do they have social motivation? Are they not interacting with the other kids because they just don't want to, they just don't prefer to, and they want to be alone? Or is it because they're scared of what those kids will think of them? Have they been really bullied and had a lot of peer rejection, and now they're not interested in initiating with kids at school? We think of that differently. If they've been bullied a lot, that's more of a realistic fear and a more realistic anxiety about initiating. We check in about theory of mind and social awareness. So are they able to understand other people's perspectives? Does it seem like they're even able to understand that other kids could think negatively about them? And what their social opportunities are. Sometimes they're very limited. We also check in about general hypersensitivity. and perseveration. So if you're trying to consider whether a kid who's in a big crowded social environment, you're trying to figure out if that's social anxiety, I find that it's important to know, are they just really hypersensitive? So it's not about the people, it's maybe about the lights or about the noises, and that's an important consideration. And also, are they just perseverative in general, and it's not just about their worries? So, if you're giving a generalized anxiety diagnosis, you want to know, do they just get stuck on all topics, or is it more specific to worries? And we're going to touch on these as we go through. So this is a very new area that we're just trying to figure out. There are some things published on it, and like I said, this addendum will come out in the new ADIS, so we're going to be learning more about it. But what we think, why we're so excited about it, is because we think a lot of kids were kind of getting missed because people were saying, oh, that's just related to autism. And it's like, well, if it seems like a clinical level of anxiety and they could actually be treated for it, that seems really unfortunate to just say, oh, it exists within the ASD diagnosis. But then just giving many kids other specified anxiety doesn't feel like that's really doing the best job either, because then, it's harder to do research on these other areas to know, do these atypical specific phobias respond to treatment in the same way? So this is sort of a pretty new area that we're trying to sort out. Okay, and I might have talked about some of this already, but what's the point of figuring this out? One reason is that there's some recent research suggesting that traditional parent and self-report questionnaires that measure anxiety, like the SCARED and the BASC, do not have the level of sensitivity needed to detect clinical levels of anxiety in kids with ASD. So that means that the cutoffs that we use for typically developing kids for these measures are not picking up kids with ASD who have clinical levels of anxiety. So they're talking about recommendations to lower the cutoffs on some of these measures, but then what can happen is you get kids who show up to have anxiety disorders who really don't. So you get false positives. So our ways of assessing this, if we just use questionnaires right now, is not so great. There's some work being done to adjust questionnaires specifically for kids with ASD, but it's just not catching all of them. This can help inform clinicians of how and when to give the additional diagnosis, like I mentioned. To reduce diagnostic overshadowing, which is the failure to diagnose a mental health condition in the presence of a more salient disorder, such as ASD. So that's kind of the word for what was happening for a long time. They were just getting ASD and the anxiety wasn't being recognized. And you can do something about it if you know where things stand diagnostically. So Connor, Dr. Kearns talks about anxiety and ASD is a problem with promise, that we know that we have treatments that can actually help the anxiety. So if we know where things are diagnostically, we can use these treatments we have to help them out. And also to help clinicians know the best way to treat them. So we're just starting to do research in this area. We don't, like I said, totally know if kids will habituate to the exposures with these atypical fears, or if there's something different about them. Okay, so I don't have all the anxiety disorders up here. The DSM-5 took a change in that it went from OCD was counted as an anxiety disorder, and now there's anxiety disorders and obsessive compulsive and related disorders. And I just put up the main ones that, for one, I see in the clinic and that we're going to talk about today. And so under anxiety disorders, there's separation anxiety, social anxiety, generalized anxiety, and specific phobias. There's also panic disorder, agoraphobia, and selective mutism. And I'm not going to talk about those too much today. Under the obsessive compulsive and related disorders, this new area in the DSM, there's OCD, there's trichotillomania, which is hair pulling disorder, and excoriation is a new disorder, and that's skin picking. So you can read up here, they all have some fear or anxiety present, but the anxiety in OCD or OC and related disorders vary in terms of kind of the content or how it affects them. We'll go through some of these in detail, but right here I want to focus on trichotillomania and excoriation disorder because I'm not going to talk about them more today. Trichotillomania is hair pulling. There's urges to pull hair. It's often connected to stress, anxiety, or boredom. It doesn't always have to have a component of stress or anxiety. And the treatment for both of these disorders is called habit reversal training. So that's the empirically supported treatment for this. If somebody has hair pulling or skin picking and they're not getting HRT, they're not getting what has research support behind it. And the reason why I wanted to mention them for the practitioners out there, people that might see this, trichotillomania, you always have to make sure to ask if the kids are swallowing the hair. It seems kind of gross, but it happens, and it has an important medical reason, because if they're swallowing the hair after they're pulling it, they can get something called a trichobezoar. It's a hairball in their stomach that can cause a lot of medical problems. So if you ever see this, I have kids that come in and they have a patch of hair missing, but they do a very creative headband to cover it. So you might not always know this, but if you see hair missing, you do want to look into that and make sure that, for one, they're not swallowing it, but there is treatment for it. Excoriation, skin picking disorder. It also, from a medical standpoint, some kids just pick a little bit, like their cuticles or around their fingers. I've worked with an 8-year-old with ADHD who she picked down so far, she got a bone infection, and she could not stop picking. So even though she had a bone infection and exposed wound, she was still picking. So we want to make sure this is being paid attention to and that they can get the treatment for it. Okay, so I'm just going to go through these traditional anxiety disorders quickly. I'm not going to read all the criteria for them. A lot of this stuff is mentioned in the DSM, but I want to specify what we would want to consider in ASD, especially with this autism spectrum addendum that we know about now. So separation anxiety disorders, they're typical separation fears. They usually outgrow them by 5 or 6, but we usually see separation anxiety disorder in kids more 7 to 11 who are still really struggling with this. They have a lot of anxiety regarding being away from their caregiver. And some kids are even so anxious that they don't want to be away from them within their own house. So they won't go to the bathroom if their parent doesn't come in, or they won't go anywhere in their own house without their parent. So in ASD, one of the considerations we want to think about, some of them are is this child so dependent on their caregiver? So if the child seems really anxious about being around their caregiver, you want to know, like, is there a realistic reason for that? One child I saw, he was an adolescent. He was functioning in the range with intellectual disability. His mom was the one who knew his communication device the best and who delivered the reinforcers in the way that he liked. So he was really dependent on her for his functioning, and it just wasn't the situation where lots of other people did this as well for him. So, is it separation anxiety, or is that he's so dependent he really needs her and there's not other people who can get his needs met? So some kids might look like they have separation anxiety, but it's really this fear of change or negative reaction to change that I talked about. So a child who's asking, their mom, are you coming home at 5 o'clock? Are you coming home at 5 o'clock? Are you coming home? It might look like they're worried about being separated, but if you really look at the details, it might just all be about the routine not changing, that I'm worried that you're going to be late, and I can't handle that because I have this fear of change, and that's going to really cause me problems. And are you picking me up today? Are you dropping me off? Might not be about the attachment to the person and the worry about that, but about the change in the schedule. Social anxiety disorder. Like I mentioned, the real main thing to consider here is whether the child feels like they'll be negatively evaluated by others. So just being anxious in situations with other people is not the same as is meeting criteria for social anxiety disorder. It really has to be about the worry of negative evaluation or whether they'll do something embarrassing in front of other people. This is sometimes hard to figure out in kids with ASD. Like I mentioned before, the ASA is helping us with that. And it actually says in the DSM-5 that the fear, anxiety, or avoidance must not be accounted for by another mental disorder, for example, ASD. So you want to consider, like I talked about earlier, do they have the social motivation to do it, or are they just not interacting with other people for another reason? You don't want to assume that it's because they're worried what those peers will think of them if that's not part of what's going on. So generalized anxiety disorder, these are like the what if kids, lots of what if questions. What if this happens? And, I mentioned some of those at the beginning. What if, they think I'm so anxious because I can't breathe? Or what if my water breaks? Like this is, stuff that's very, in kids with GAD, you're just usually hearing these what if questions left and right. So they have worry about very kind of everyday things that come up. School, performance, homework. I have this example here about trip to Disney. So I was seeing a kid and he was worried. They found out they were going to Disneyland. I thought he'd be excited about that. He looked really stressed. And I said, what are you worried about? What's going on? And he said, well, someone hit our car this week. So we have to take another car. And I'm worried that car won't be as safe as our car. And what if someone breaks into that car and gets our suitcases out and then it ruins our trip? And so we talked about that and locks and things like this. And I just wanted to see how far it would go. This is before we'd really started a lot of treatment. And he said, okay, so maybe somebody won't steal all of our stuff. What if somebody runs into the car, the new car, and then it's a problem because the car won't work and we can't go? So I talked to him about that, and he said, what if the repairs take all of our money and then we can't go to Disney because we don't have the money? And then we talked about that, insurance companies and how they work. And he said, what if that insurance company goes bankrupt on the day that we're supposed to go to Disney and we cannot get that money to go to Disney? And so it was like such a little indication. I let it go, because I wanted to see how far can this go? And he had just what if after what if, and it was consuming. He couldn't even enjoy the idea that his parents just surprised him with going to Disney because he was so worried about it. So again, with ASD, we want to consider these special interest fears. Are they really worried about access to a special interest and it's not more generalized? Do they have general levels of perseveration? So they kind of perseverate about everything and not just anxiety or worries. And again, this fear of change and negative reaction. Specific phobias. So there are some of these kind of traditional ones that we see, like animal-related ones like spiders, heights, receiving an injection. Vomiting is one. That treatment is real fun because you get to make vomit and you get to, pretend to vomit. Loud noises. One thing in kids with ASD we have to think about, is it a loud noise phobia or a general hypersensitivity? And so I have down here, this one I didn't mention earlier, this picture down on the bottom right. It's the trailer to the Columbia Pictures when a movie's going to come on. And I saw a child. He was functioning in the level associated with intellectual disability, and he had an really extreme, intense fear of this trailer coming on. And so anytime a movie would come up, when this came on, he would get really upset, cover his ears, run in, go on his bed, cry, really distressed, knew exactly how long it would last. And at the end of that, he would come back out. And it didn't seem like a lot of interference until I figured out that he ran out of his classroom a number of times if they watched a movie where this came on. And so that's a huge problem, right, to run out of your classroom because you have such a fear of this movie trailer that is one of these atypical phobias that we're not really sure, does it respond to the same way to treatment? So in ASD, you kind of have to consider these other areas, or with this autism spectrum addendum, it would take you through it. So obsessive compulsive disorder, it has to have this thoughts or impulses or images that are intrusive, inappropriate, and distressing. And these compulsions that the person feels like they have to do to reduce the anxiety or distress or prevent a dreaded outcome. So OCD, the content is usually a little more irrational. So some kids, like I said, they might get diagnosed OCD when they're it's a special interest thing with video games, and that doesn't really fit. You have to have this part about they're performing the compulsions because they feel really distressed about it and like they have to do it. And then, so in ASD, you want to think about, there are repetitive behaviors, but you want to think about, are they actually self-soothing, or are they preferred? Does the child seem to enjoy doing those repetitive behaviors? And can they indicate whether it relates at all to an obsession or a concern that something bad will happen? And one of the in a child that I saw with OCD, if you can really get into it, you can figure out, I'm going to give a little case example about someone too, but you can figure out, you know, what are the rules of OCD? It can be really complicated and really, you know, seem really unusual. So some people, I saw a kid with harm OCD who had lots of thoughts about he was going to pick up a knife and stick it into a parent or stick it into his own neck. And, you know, somebody thought he had psychosis, and they went down that route when really it was OCD. So you have to make sure you're considering these obsessions and compulsions and how they go together. So in terms of differential diagnosis, it's not always that easy, even with the traditional anxiety disorders, and now we're sort of working on this new area in ASD. I've talked about some of this, but social phobia versus GAD. So in social phobia, again, it really has to be about the concern of what other people think of them. In GAD, it's like the everyday worry. Like, I'm worried about school, my own performance, how I'm gonna do. If you're thinking about GAD versus OCD, so recurrent thoughts, avoidant behaviors, and repetitive requests for reassurance occur in GAD too, but the content, again, is about these everyday real-life events, whereas OCD, it's usually a little odd or irrational. Like if something got in that cup that could be poison, and then I eat that, and then I drink out of that cup, I'm going to be poisoned. So I need to not drink out of that cup and do all these things to wash around my mouth or wash my hands to make sure it didn't happen. So it seems, it doesn't, you know, it seems like not real-life stuff. Skin picking, hair pulling, nail biting versus OCD. So if there's another disorder going on, you shouldn't be diagnosing OCD. So even though hair pulling could seem like maybe they had an obsession or a thought and they feel like they have to pull their hair to make it better, that's a disorder that we have. So you should be considering trichotillomania and not considering OCD, even though it looks like it has something repetitive about it. Eating disorders versus a specific phobia, vomiting or choking, versus OCD, or a new DSM diagnosis, avoidant restrictive food intake disorder. So eating disorders is really about the fear of becoming fat or gaining weight, and that fear needs to be present. A specific phobia of vomiting or choking is really, they're so scared of that specific act happening, vomiting or choking. I had a child who had a really strong phobia of vomiting, and she was an anxious little first grader, and she felt like she had to vomit. And her teacher, she said, "Can I go to the bathroom?" And her teacher said, "Just hold on a minute." So she vomited in her mouth and held it there because she was too anxious to just say, "I have to go." And after that, you can imagine she was very scared of vomiting again and going through this and everybody vomiting. So it was really about vomiting. It was clear it wasn't about anything else. It was so specific to vomit. And again, OCD, if it was OCD related to food, it would be more about worry that their food was poisoned or something was going to contaminate them. And this ARFID, I don't know if people actually call it that, but the name is really long. These are kids who have the picky eating and the sensory stuff and might show up in feeding clinics. So it's not about gaining weight, it's about, you know, the food. And then ASD versus social phobia versus OCD. So in ASD and OCD, there's the repetitive behaviors you don't see in social phobia. And I think maybe if you haven't learned anything today, it'll be that you'll leave knowing that social anxiety disorder really has to have fear of negative evaluation from others. That's like the main piece of it. And so, you know, we don't know that that necessarily has to happen within ASD. So you're really sometimes getting into these different areas can be very tricky. Okay, so what is CBT? The primary goal is to identify and challenge dysfunctional beliefs, catastrophic cognitions, and automatic thoughts, as well as to change problematic behavior. So that's very wordy. And we'll talk about what some of these cognitions are and how we think of them and how they affect behavior. The programs are designed to create new ways of responding to the anxiety, so like coping skills, and we use techniques like modeling, exposure, relaxation. There are usually 4 critical components of CBT. So I've been talking a lot so far about the assessment component. It's really important because if you don't actually know which area it is, you might not go down the right treatment path for it, or you might have missed that it's really a skill deficit that needs to be targeted in a different way, like they need more reading help versus targeting their anxiety as if it's excessive. The psychoeducation portion, where the therapist is the educator, and they foster skills in areas of relaxation, social skills, awareness of physical symptoms, and automatic self-talk. Automatic self-talk is what I gave you a little sense of, like my own self-talk coming here today, and we all do this all the time. We may not notice it. Sometimes it's not about anxiety component. We're just thinking through things, but some little kids, it's like the little what-if kid about Disneyland was lots of anxiety. The practice phase, where we put these skills into place, and I'll go through what thinking traps are and how to challenge these thoughts. And I really focus a lot with kids on externalizing the anxiety. So I explain to them, I don't see this as something that's a part of you. This is kind of something that's happening. Let's call it a name. If I can get them to fight back against it, like it's a bully, that usually is really helpful. I pick characters, like one kid, we did all the therapy through him being Batman, and the anxiety was the Joker. And he just it was a special interest, so he was really into it. And we talked about, how are you going to fight back against the Joker? Are you going to let him do this to you? I don't think Batman would. And that really helped him to do it. And then exposures are really important. So we can't just talk about the thoughts and come up with coping thoughts. We have to expose them to the situations that are feared, let them see that they can get through it and get past it, and anxiety will come down. So the cycle of anxiety here, if we look at it, up on the far left, the anxious interpretations, like somebody saying, say there's two girls at a school, and one girl wants to make friends. She wants to go up to them, but she says, oh, they'll think I'm stupid. I'll do something embarrassing. So this will be social anxiety. She starts noticing that she has physical, somatic sensations like muscle tension, butterflies. So she decides, you know what? I don't need to make a friend today. I'll just get out of this. I'll try tomorrow maybe. And she avoids. So she escapes or avoids the situation. So when you escape or avoid it, what happens is, over here, her anxiety would go down some. And then she would be reinforced for that happening and be more likely to avoid next time. So the treatment, the X there, is what you really need to do is you need to knock out that escape or avoidance so that they can see they can get through it. We would really want her to still do an exposure, approach the other girls, feel really anxious, and get through it, and over time that will get easier. Okay, so considerations of a goodness of fit for CBT. So like I mentioned, a lot of people, there's a lot more awareness that CBT is an effective treatment for anxiety disorders, but that doesn't mean it's appropriate for every child. So some things to consider, are they motivated to do any of the work? So if the kid comes in and I talk to them and I say, I try to assess the areas, no, nothing's wrong, nope, no anxiety, nope. And I talk about maybe some things we would do. Would you consider doing that? Nah, don't need to. Nope, I'm not doing that. Or they don't talk to me at all. So there are some options. You can try to work with parents and do parent training and get them to start. But sometimes they're just too young or they're really unmotivated and they have to make the decision that they want to do this. So some therapists will be really firm, and if it doesn't seem like the child is willing to participate, they'll say, I'm not going to do this because it's not going to work for anyone, and they are not going to, they're not going to want to come here, and it's not going to be helpful. Any comorbid conditions, so again, we're going to talk some about CBT and ASD, but if ADHD particularly is unmanaged and it seems like it could be managed more, that's always going to be a preference, because if they can't attend at all, or if they're really hyper, they're probably not going to benefit from an approach that has a cognitive component to it. Level of cognitive functioning, like I mentioned in the beginning, we don't know a lot about CBT in children with intellectual disability. We're learning a lot more about CBT in high-functioning kids with ASD, but the research hasn't really gone there yet. So a lot of people think an IQ of 80 or 85 to benefit. And the reason is you need a lot of cognitive skills to do the cognitive part of CBT. So metacognition, thinking about thinking. If you don't think the child has ever thought about their own thinking, it might be hard to implement these skills and to try to work on it from this approach. And also parental involvement. So I sometimes have parents, depending on the child's level of functioning or what's going on, sometimes I have them in every session, all session. And I didn't used to do that as much, and I've even considered, therapy is supposed to be about like the child having the space with you and the confidentiality to express things, but some kids it seems like it's way more important to have the parent be able to generalize these skills and to spend the time seeing everything you're doing. So I have them in the sessions. I've considered, we have observation rooms at mine with one-way mirrors. I've considered sometimes having parents back there that I would tell the child, but back there to just see what I'm doing and not be in the room. Okay, so if you don't think that they're a good fit yet for CBT, what can they do? And the behaviorists in the room will not be surprised by this. There's a lot of really good behavioral intervention that can occur that is really working on anxiety and fear. So you can get a functional behavioral assessment to understand the ABCs, the antecedent behaviors and consequences, and how to work on exposures. So what I have up here, if you're not aware, Autism Speaks has these toolkits that are really amazing. They're free to download on their website. They have them for a variety of things. Two that I use in particular with my work, they have a blood draw toolkit, and here's the table of contents. It's very detailed. And they have a dentist one. They have many. And it's really taking the parent or the professional through the behavioral approach of how you would get them to do these things and desensitize their anxiety and fear using visual schedules, all of these things. So there's no real C there. There's no real cognitive part that they're working on. It's behavioral therapy, and it's quite effective. So if a child doesn't seem quite ready for the CBT approach, there's lots of behavioral things that can be tried. Here's another, more on the behavioral side. This has some cognitive components. So socialthinking.com is a website that has a number of programs available. Superflex is one of them. It really gets kids to think about these different characters and how they can develop their own awareness of their own thinking and their own social behaviors and strategies. So there's books about this. There's all these characters you learn about. You learn in more of a concrete way what happens if you're glass man, what can you do about it. And this is another one that I've heard about more and more recently. I don't know the empirical evidence on these programs. I don't know that they've been researched. I know anecdotally they're really helpful. So Zones of Regulation is also on that website you can learn about. And this is something I've seen teachers for a really long time use programs in their classrooms about like you're in the red zone, you're in the yellow zone. This seems to take some difference in that it really teaches kids if you're in one zone that's not going well, and you need to get back into the green zone, what can you do from a really more of a concrete perspective? So it's some cognitive component, but it's not the same as if you were getting a formal CBT treatment. So those are kind of things you could do if the child's too young, or depending on those items to consider, those factors to consider, what could they do to help these areas before doing CBT? So there are some empirically supported treatments out there for treating anxiety disorders. The Coping Cat and the CAT Project are two that have a lot of research evidence. These are for typically developing kids, but they are adjusting the Coping Cat for kids with ASD, and they found that about 58% of the kids with ASD, they lost their primary anxiety diagnosis after doing this adapted version, so it's not published yet, but it will be. The Coping Cat is for kids 7 to 13, and the CAT Project from 14 to 17. And I have my Confronting Cat over here because the way I was trained was it's so much about confronting and exposure. You do the cognitive parts, you might do relaxation, but you really need to get them to confront their anxiety. It's not just like coping with it or dealing with it. And of course, you would not put that scary cat on a manual for children. So that is my own scary cat I found on the website, on a website. But you know, the coping cat is sweet and nice, but you really need to never forget that part about exposures, and it's about confronting and dealing with it. So here are just some Coping Cat program components. And I use the Coping Cat with children with ASD and ADHD right now without there being a formal, program published. I just adapt this in the way that I feel like I need to adapt this for the child based on clinical experience. And often it works quite well. There's, it's a manual, there's these cute pictures in it and things that they can do. So you're really, the focus of the program is teaching them about how to use the fear plan. So you'll see the parts that are highlighted here. They need to learn how to know they're feeling anxious, that they're expecting bad things to happen. These are, I call them e-thoughts or anxiety thoughts. They learn the A part, which is the attitudes and actions that can help, and then the result and reward is usually like, oh, they feel better, that worked well, they had a better experience with the kid because they did the exposures or the A part. So I'm going to show you these parts in more detail. Here's just some examples of some pediatric anxiety exposure examples. So how I said I'm like big on exposures, you have to confront it, you have to do it, you can't just talk about it. So for separation anxiety, a hierarchy we might develop would be something like, these are very brief hierarchies, usually they're much longer than this and very detailed. Like maybe at first the parent just leaves the room or office for like a few minutes. And then maybe you get to the next goal or exposure of staying in their bedroom alone for 1 hour. And then you go on from there. So we always develop these hierarchies, and we always do exposures, and don't forget that component. In social anxiety, it could be they join a group or a club. They need to respond to the approaches of peers. That's sometimes easier usually than initiating, so that could be next. They call a peer on the phone. They invite a peer over to the house. Our social skills program, I just was reminded by looking at Dr. Goodland-Jones over here, our social skills program at Mind has some of these parts infused in that program, and it's stuff that I do too about connecting with peers, initiating conversations, but I do this, from a social anxiety perspective. I mentioned vomit a couple times. It's, so much fun. I have a recipe for fake vomit if anyone needs it. And so you create a hierarchy and you work through these steps of getting to the point where they can go into school and not be wondering the whole time if the child next to them is going to vomit. And so GAD, answering questions wrong on homework or tests on purpose, don't reviewing their homework, reading about stories of Ebola rather than just scared to death they're going to contract it from the doorknob or something. So worrying, these everyday worries, doing exposures to them. So this is kind of my little motto for it, and why, again, pushing why exposure is so important. Sometimes the smallest step in the right direction ends up being the biggest step of your life. Tiptoe if you must, but take the step. So I have an adolescent with social anxiety. She just cannot get herself to call a peer or to do some of these things. So we talk about what's like the most little minor thing that you could be doing that was more than what you were doing yesterday. And this is, I want her to like put this in her bedroom or something and look at it. So to go back to the fear plan again, the F is feeling frightened, so you get them to recognize their physiological symptoms of anxiety. The E is all about expecting, what are those thoughts related to expecting bad things to happen? So the CAT project talks about thinking traps, and I get them to identify what theirs are. So like an example, the catastrophe, always thinking the worst ever is going to happen. Or the perfectionist, setting expectations that are too high, or saying things like, I'm not good enough unless it's perfect. So if you can get them to identify that they're having those thinking traps, you can figure out what to do about it. So it's knowing that you've had an e-thought is part of it, but also that awareness, getting that part down, then we can go to the next step. So a lot of kids that are really anxious are kind of in the F and the E. They're kind of feeling the uncomfortable symptoms. They're expecting everything bad to happen. And what the treatment does is really teaches them to move out of that into the A step and to do something about it. So examples of attitudes and actions that can help are coping thoughts. Like, so I'm not perfect. I don't know anyone who is. So if they're feeling really anxious about something, get them to stop that anxious thought from flowing and use a coping thought that's more realistic to the situation. Again, exposure, you expose them to the things that make them really anxious and see that that's an attitude and action that can help because they can get through it and have a successful experience. Problem solving, we talk a lot about if you're anxious about something, can you problem solve it or can you not? And if you can't, it's hard, but you kind of have to accept it. So I give, usually what's present on my mind is sitting in traffic on Business 80, going to the Mind Institute. So I talk to them about if I feel like I'm going to run late. Do I just sit there with really uncomfortable feelings and thoughts about, oh, people are going to be mad, I'm late for a meeting, uh-oh, my patient's waiting for me, or is there something I could do about it? Could I call and tell people I'll be a couple minutes late? Is there an exit I could take and take another road? So if you can problem solve it, that's always advised. If you can't, you kind of just have to sit there and say, okay, I can be so upset and miserable and stressed out right now, or I can say, I've never been late before. I think they'll understand. There's clearly some accident or something, and this is gonna be fine. And then you can teach relaxation, and the R again is just the result or reward. What happens if you've been able to work through the A step? So this is an example of a much younger kid trying to do the fear plan. And so it says, I was nervous, scared, or worried when I swam in the swim meet on Sunday. His body reacted by shaking. He was thinking, I'm going to do horrible. Instead, he thought, I will try my best. And the attitude and action that helped him was, my parents are going to be proud of me no matter what. So this is like obviously a much younger kid doing this, working through this, and trying it out. On the other side, I was nervous, scared, or worried when I sat on Ethan's ankle, which annoyed him. My body reacted by butterflies. I was thinking Ethan would not like me anymore. Instead, I thought Ethan will forgive me. And his attitude and action, which shows you kind of how immature he is, but helped at the time, is that everybody forgives you for something you've done. He will learn that's not true, but at the time, that was helpful. We're not doing everything at once here. And he did well. He didn't have guilt anymore around Ethan. So you get kids to, this manual has these that they can work through. Okay, and then this is my little treatment for anxiety is like a 30-some-year-old learning how to ski. This is me, like moving to California and going to Tahoe not that long ago. And so, we all have anxiety about things. And what I found interesting is the ski instructor kept telling me, lean towards the danger. And I was like, what? That's insane. But if you think about it, that's kind of what you're asking kids to do with exposures. You're asking them to lean towards the danger, to face it and push in there and deal with it. You can use coping thoughts. You can get up after you fall, and then you reinforce yourself at the bottom of the hill. And I won't say, what I do, but, food, drink, whatever, at the bottom of the hill, if you've managed to get down at the bottom with all your limbs. So it's kind of the same. So this is a 15-year-old who had a previous diagnosis of Asperger's syndrome. She was very talented at art, a conscientious student, and took pride in doing well in school. She had OCD symptoms since the age of 8 and lots of just right feelings, like she needed to wash her hands or shower in a certain way until she felt just right. It wasn't about preventing getting sick or something. It was just a feeling that she needed to achieve. She had a lot of obsessions about whether she was breathing properly, whether her heart was beating enough or just the right way, whether her eyes were moving the right way. So again, this content with OCD that seems a little bit odd. And she was constantly working to kind of get this just right feeling. So basically, that she had an OCD diagnosis that was a pretty clear traditional OCD outside of the, ASD. That it was a pretty traditional form of OCD. The eye stuff I hadn't really heard before, but the washing and the just right feelings. So we made hierarchies for her, and we worked through it. We used a lot more concrete terms because she, the abstract language that I use sometimes, like, who's talking right now, the OCD or you? And one child told me, well, both, because I think the OCD told me to say it, but I said the words out of my mouth. And I was like, Okay, you're right. Let's not use that one again. So she was able to work through this treatment and get all of this down, but it had caused such impairment that she wasn't going to school anymore and wasn't interacting with peers. So now I'm just going to talk a little bit about the pediatric anxiety treatment efficacy data. So this is in typically developing children. So this is a trial that was looking at, it was a large randomized controlled trial looking at CBT versus SSRIs versus a placebo, or both, having both CBT and sertraline at the same time. And so the children were 7 to 17 with moderate to severe anxiety disorders. And this is what I tell parents. We do not have, that I am aware of, any studies like this that was done this systematically and randomized for medication versus CBT versus both for kids with ASD. So this is in typically developing children, but when parents ask me, what is the research on medication versus CBT for my child with anxiety disorder, these are the studies that I'm citing. So as you can see here, they call this the CAMS study, and the outcome was that combination had the highest percentage of treatment responders. So it had 81% if they had both medication and CBT. That was significantly different from having one or the other alone. So if they had just CBT, 60% were treatment responders versus sertraline or Zoloft, 55%. And then you can see the placebo is much further down there. So generally, based on this research and the other studies they've done, combination together is going to give the most chance for an improved outcome. And then sertraline and CBT aren't different from each other, but some people talk about the longer term skills that they could learn from CBT would be helpful down the road. So that's just what we know in typically developing children about this. So how do we adjust these treatments for children with ASD and ADHD? They talk about altering the structure, delivery, and content of CBT programs for kids with ASD. So just doing it the same way and using the same content might not always work. Incorporating social skills and adaptive skills in areas that they're having problems with might be really necessary. So if a child is not completely dressing themselves yet, or they still wear a pull-up sometimes or something like that, and you're expecting them to have a play date and feel confident around peers who aren't doing that, that might not cut it. You need to focus on that first. You can't just send them into the play date knowing that there's this adaptive skill that's a problem. Using concrete language and visual tools. I mentioned this, who is talking, the anxiety or you, and to try to make that as concrete as possible, incorporating their special interests by using like the Batman and the Joker piece and involving parents. And so they talk about ADHD as you don't need to alter the content of what you're talking about as much, but the structure and delivery. So having breaks, using point systems, making it interactive, making therapy distraction-free. I used to do this therapy in the middle. It was a tall building in Philadelphia where you could see the whole skyline, and there was always construction, and it was always, my kids with the attention difficulties were like, oh, what's that guy doing out there? And, oh, look, a storm's coming. And it was like the therapist's office that I used had a lot of like dead bugs for the exposure she was doing. So she had like jars of dead bugs, and it was like, oh, I see a dead bug. I'm like, oh my gosh, we need to like close the blinds and make this, more distraction free so we can focus. So CBT programs for specifically for children with ASD. There are a few that have been developed now. This is a very comprehensive one. It's called Behavioral Interventions for Anxiety in Children with ASD. It's out of UCLA, Jeffrey Wood's work. They call it BIACA, which reminds me of Banaka, the breast spray in the 90s, but it's not the same. And you can see this is it's a individual program, but it has this modular treatment algorithm. So you could figure out, it is not just about anxiety, it's about all these other areas too. If they have adaptive functioning problems, you need to focus on that. If they have social skills training needs, you might need to branch off and focus on that. So these are 16 90-minute weekly sessions, And there's high level of parent involvement and there's school consultation. So it's very, very involved. I don't know if insurance would ever pay for this. I haven't found out yet. I mean, what we can typically get paid for are 45-minute sessions, so 90, I'm not sure how that would work, but this is a very comprehensive program you could look at more. And then another one, Facing Your Fears, is a group program for treating for CBT in kids with ASD. And this is also, it's 14 90-minute weekly sessions, youth ages 8 to 14. And they really work through the programs. They adjust things for kids with ASD by using token reinforcement schedules, visual structure, comprehensive parent curriculum. And so this is in a group format. And I'll talk a second about the evidence for this. And they seem to have good treatment effects on this, but you aren't able to get at the individualized problems with the kids. You're focused more on the group. This is a study looking at lots of different studies on children with ASD and cognitive behavioral therapy. And what I can tell you here is that it's kind of hard to see that over there on the screen, but about half of the kids showed positive treatment response or no longer met criteria for a primary anxiety disorder. So they're finding that the rates of treatment response in kids with ASD when using these programs are pretty similar to actually typically developing kids. That, like I showed in that original slide, 60% of kids in that big CAM study were considered good treatment responders. And so a lot of these studies specific to ASD, they're finding about somewhere between 45 and 60% have really positive outcomes following the program. There's a lot of variation, though, in what these studies focus on. So they're talking about, we need to do more research and make it more systematic. Some include parents a lot, some do a lot of exposures, some don't. Some are group format, some are individual. So we're still looking into this, but it's very promising that they've developed these programs and that they're getting about the same treatment response as what we have for the programs that have been around a long time for kids with typical development. So just the summary of considerations in assessing, diagnosing, and conducting CBT for children with ASD. Again, consider whether it's general behavioral or emotional dysregulation versus clinically significant, that's the ADHD one, sorry. For ASD, again, thinking about these atypical forms, and more research will be out on this and more measures will be out on this. Traditional anxiety questionnaires might not be sensitive enough, so if you're giving parent report, the common ones we give out, it might not catch them, even though they have clinical levels of anxiety. Consider diagnostic overshadowing. Are we just thinking about it as ASD when really we need separate attention to the anxiety? Focus on adjusting when you're treating the structure, delivery, and content of the CBT. So make it more concrete, use visuals, use their special interest, incorporate parents as much as possible. Consider taking the C out of CBT if you need to at first. And then with ADHD, again, what I was saying before, consider whether it's just behavioral dysregulation or the ADHD is just really unmanaged, and going down that route would be a first step before referring for CBT. And maybe one of these alternate approaches. I've seen a lot of kids who are doing the Zones of Regulation program, and it's really helped them. And sometimes once they do that for a while, they can come back and see me. And that's helpful because it's like at home and school, so it's more comprehensive, and then they can work on the other areas. And altering the structure and delivery and not necessarily the content. Okay, so the last thing is just this idea of the whole hope is that we can teach these kids to feel the fear and do it anyway. So we don't expect anyone to never have any anxiety, but it's about feeling the anxiety and doing the exposure and approaching the things in your life versus, impacting your functioning and avoiding.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.